Um, I, I understood my assignment to say a few words about the healthcare delivery system in the United States and how that relates to the medical education system, how medical schools can take advantage, if that's the right word, of the healthcare delivery system in the U.S. One of the things that has come up in the last two presentations, and maybe some of the others, is whether healthcare is a right or not, whether there is a right to healthcare. And in the United States, that has been tested in the courts, and the courts have consistently ruled that there is no right to health care in the United States. There is nothing in the Constitution that guarantees health care, with one exception, and that is prisoners. Prisoners in the United States have been found to have a right to health care, but nobody else. So Charles comments that that is the reason we have so many people in prison, and actually there is some truth to that, because there are particularly men with HIV infection who intentionally commit crimes so they can go to jail, so they can get their medication, because that's the only way they can do it. This is true. So having confessed to that, that will help support my contention on this slide that we have the world's most expensive healthcare system, and there's no debating that. The healthcare in the United States on a per capita basis costs at least twice as much as the second most expensive healthcare system in the world. The last time I checked, that was Switzerland. That may be old by now. And the most dysfunctional healthcare system in the world. And somebody else here may think that they have a dysfunctional healthcare system, but I would challenge anybody to show that theirs is more dysfunctional than ours. So we have an entire course in our Master of Public Health program on the healthcare delivery system in the United States. I will say a few words about it in a few minutes, and hope that this is sufficient. These are what I would call the components of our healthcare system, perhaps any healthcare system. We have hospitals, we have facilities in which individuals receive care on an outpatient basis. Then we have an entirely separate system of public health departments. And then I include communities as part of our healthcare system, even though people in communities don't necessarily get reimbursed for the health services that they provided. They are still a very important part, and one that needs to be taken advantage of by medical schools. So we have private hospitals and we have public hospitals, of course. We have private for-profit hospitals, and these are mostly in the form of large hospital chains, such as HCA and Tenet. These are very large corporations, the medical industrial complex that was referred to by the previous speaker. And then we have private not-for-profit hospitals, which include medical school hospitals. Some medical schools own their own hospitals. There are religious hospitals. There are community hospitals that are owned by private, not-for-profit corporations that provide health services in the community. Then on the public sector side, we have local hospitals, state-level hospitals, and national or federal-level hospitals. And I have divided local public hospitals into two categories, non-charity and charity, because there are county and city hospitals that are publicly owned. They are owned by the government, but they are run as if they were private hospitals. And the medical staff consists of private physicians, and the patients are expected to be insured or to pay for their medical care. But then in large cities particularly, and not every large city, but most large cities in the United States, including Atlanta, there is a public hospital that serves the poor. And I have put that in red because this is a site where medical students may first encounter poor people. They may first have the opportunity to provide medical care to the underserved. And you'll notice that all those other hospitals that I listed were not in red, because in those hospitals, even though any of them may be used for medical education through an arrangement and agreement with a medical school, the patients that are cared for there are middle class and above, with an occasional exception. And so medical students do not have the opportunity to serve the underserved there. But in Grady Memorial Hospital in Atlanta, Jackson Memorial Hospital in Miami, Bellevue Hospital in New York, and so forth. Medical students have the opportunity to serve the underserved. At the state level, there are some medical schools, many medical schools that are state medical schools, and they may have their own hospital, so that hospital would be owned by the state. States traditionally own mental hospitals in the United States, and there must be some historical reason for that, but that's the case. It used to be that there were state tuberculosis hospitals, but most of those, maybe all of those, have closed now. And then at the federal level, there are hospitals that are operated by the Department of Veterans Affairs. These are hospitals that are for veterans, but not really all veterans, veterans who cannot afford to obtain private medical care in a private hospital, go to the Veterans Hospital. And most of these, or many of these, are affiliated with medical schools, so they are another place where medical students may serve the underserved. We have a separate government system that provides care to Native Americans and Alaska Natives. It's called the Indian Health Service, and some medical students have the opportunity to participate, and so that's another place. And then, of course, we have military hospitals. On the ambulatory side, we have private doctors have their private offices. They may be alone, they may be as part of a group, they may be part of a health maintenance organization, in which case they would be on salary rather than collecting a fee for service in most cases. And we have urgent care centers, walk-in clinics where people frequently go for minor health problems, usually minor health problems, and they are convenient, but of course they lack continuity. Then there are community health centers that are subsidized by the federal government, but they are operated by local not-for-profit corporations with community boards of directors. And I have these in red because this is another place where medical students may have the opportunity to serve the underserved. And many of these are now used as very important teaching centers for medical schools, and we like to encourage that. I have federally qualified health centers listed separately because there are other health centers that look like community health centers and are reimbursed by insurance companies or Medicare or Medicaid on the same basis, but they are not technically part of the same legislation. And then some of the large public hospitals that serve the poor in large cities have their own network of neighborhood health centers or satellite clinics, and I felt compelled to put that there because that's where I see patients. And then there are free clinics. There are religious groups, there are not-for-profit groups that operate clinics where they don't even attempt to collect fees for their services. They just offer them for free. And there are many clinics like that that are operated by medical students. Medical students at many schools have started free clinics and recruit faculty to supervise the students in the clinic, and those are just very valuable sources of experience for students who are interested in primary care and wish to serve the underserved. We have a whole separate system of government-run programs that provide what we view as public health, and they collect data, they tend to environmental health, they develop policy, and they provide limited services, and medical students are often assigned to public health department facilities where they can get experience with serving the underserved by providing family planning services, immunizations, well child care, tuberculosis control, health education, and sometimes primary care. That's the local health department, local health department, county or city. At the state level, every state has a state health department that collects morbidity and mortality data from the local health departments, provides consultation. They have expert epidemiologists and so forth that provide help to the local health departments, develop policy at the state level, and they may provide direct services to the public in some states. And at the federal level, we have what amounts to the federal health department, but we call it the Centers for Disease Control. You've probably heard of that. Officially, it's the Centers for Disease Control and Prevention, which collects data from the state health departments and publishes national reports on morbidity and mortality, provides support to state health departments, particularly in case of an epidemic, and develops health policy at the federal level. So that's kind of the official health system. But then in communities, there are services delivered or provided or offered through community health workers, through churches, through self-help groups, through schools. There are complementary and alternative healthcare practitioners in communities that serve many people with acupuncture or herbs or other modes of therapy that we don't necessarily learn about in medical school. And there are pharmacies, because pharmacists are often consulted by people about what medicines they should take for common illnesses and can obtain without a prescription. And these are all, I have these all listed in red because we assign students to communities. Many of your schools assign students to communities, and these are assignments in which the students will learn about how many people obtain services for their illnesses or preventive services without consulting a physician. These are services that they get in their communities, and we think our medical students need to learn about them, and this is how students learn about what makes people sick and how they think about their illness and what they feel they can do about it. Very important. So I've listed here where students learn about primary care. I mentioned doctors' offices, and these are all in white. They learn about taking care of patients in the doctor's office. If it's a rural site, they learn about living in rural areas, which is important if we hope that they will go back to rural areas. Then I have community health centers where students learn about the care of individual underserved patients, and these are places where they get, I think, a better idea of how to coordinate with the public health department, with those other services in the community, with social services that are offered by other departments of the government or private social services. So this kind of coordination is very important for providing what we are now calling a patient-centered medical home. Students assigned to community health centers are often asked to do community assessments, so they're not just seeing patients one at a time. We'd like them to learn how to think about the community as a patient and how to provide services to that community, and in order to do that, they have to diagnose the community, or what we sometimes call a community health needs assessment. They learn about community outreach, perhaps with community health workers, making home visits themselves, I hope. And if it's in a rural area, they can learn about rural life there. We've found that it is helpful when preparing to send students to community health centers or doctors' offices or hospitals in remote places or even locally. It's good to have some kind of a document that defines what will happen when the student is there. And these are the things that we put on our memorandum of understanding. The period of the agreement, how long it's supposed to last. We spell out the responsibilities of the medical school. We spell out the responsibilities of the clinical site. We list the conditions under which the agreement can be terminated. And then, because in the United States, we like to sue each other, and we would like, both sides of this agreement would like not to be sued. We put in a lot of legal language that is supposed to protect us from lawsuit, but of course it doesn't, because we sue each other anyway. And then both sides sign the agreement. And so I have an example of such an agreement, which I'd be happy to show to anybody who wants to see it. It is much too long to put on a slide. So the other site, we talked about hospitals, we talked about doctors' offices, community health centers. So students learn about primary care in the community by doing needs assessments, by conducting projects, by consulting with church groups. Students are maybe asked to do talks or help in other ways. They do projects with schools, and they collaborate with community-based organizations. These are all things we do at Morehouse, and I know many schools here do these things as well. I'd like to say a few words about area health education centers, because this is a program that really helps us link our students with doctors' offices and community health centers and hospitals in rural and remote areas, and even in Atlanta. This is a program which exists in almost every state in the United States. And it's a little bit complicated, but I think I can explain it with the help of this slide. An area health education center is usually an independent corporation that signs a memorandum of agreement with the medical school, and then the medical school obtains funds either from the federal government and or the state government and passes those through to the area health education center. And then the center may also raise funds on its own. An area health education center is a consortium or a coalition of entities in the community, including doctors' offices, community health centers, hospitals, health departments, community leaders, businessmen, ministers, and so forth. So they understand the needs of their community. They understand where students can be assigned to learn important things. When we send a student to a rural area, the Area Health Education Center helps us find housing, identifies preceptors, helps the student if there is a problem. They orient the student to the community. So the Area Health Education Centers, we call them AHECs for short, are very helpful. And so this slide shows an academic health center linked to 3 AHECs. There may be more than that. Here is my state of Georgia. And if I can get a pointer to appear, Atlanta is located here. Morehouse is located here. We have an AHEC in Atlanta, but then as you can see, there are 5 other AHECs in the state, one in Rome, one in Gainesville, one in Statesboro, one in Albany, and one in Columbus. You've heard of Atlanta. You have not heard of those other cities because those are small to medium-sized cities, but the AHECs serve the region that is indicated by the coloring on the map. So an AHEC not only helps us find sites for our students, it serves as a pipeline. And we talked yesterday about a pipeline as a program in which youth are recruited from underserved communities into medicine and into other health professions. And an AHEC does that. That's part of an AHEC's program. We think that if we can recruit kids from rural areas to go into medicine and other health professions, we know this is true. They are more likely to go back to those same sites to practice after they graduate. So the AHECs do presentations in grade schools. They offer summer programs to secondary school students. They make presentations and offer other more sophisticated kinds of experiences to college students. So then you can imagine a student who becomes interested in healthcare through a presentation when she is in grade school, who experiences a summer program when she is in high school, who goes to medical school, and then we send her back to that same place where she came from through the AHEC to get part of her training. So that's the next step in the pipeline. And then eventually she graduates and goes back to that small town to practice. But after a year or two there, she feels like she's getting out of touch. She got so much of her medical education in the medical center, where she is always attending conferences and learning about the latest things in medicine. So the AHEC also provides postgraduate continuing education. And this used to be in the form of conferences. They would host a meeting in Rome or in Albany, and the physicians and other health professionals would come to attend the conference. But now most of this is being done online. So the doctor can sit at his desk on his lunch hour and click on a website and enjoy a presentation that the AHEC has arranged. And if he can't do it that day, the presentation is archived and he can go back and access it another time. So this is really a pipeline. This is almost a cradle-to-grave pipeline, at least from elementary school through retirement, that the AHEC recruits and supports and retains providers in medically underserved communities. This has always been purely a United States phenomenon, But I've been working with some colleagues at Stellenbosch University in South Africa, and we think we'll have an AHEC program going there maybe within a year. So that's our healthcare system and how our medical schools connect with that healthcare system to provide medical students and other healthcare students with very important parts of their education, particularly if we expect them to pursue primary care careers in medically underserved communities. And I thank you.